and welcome to the Voice of South Coast Women, sponsored by the Bristol County Commission on the Status of Women. I'm your host, Gail Fortes from the YWCA Southeastern Massachusetts, and thank you for joining our show today, where our topic will be mental health. We have four amazing guests. They're going to speak about this issue to us in our community. So we'll start with Rachel, if you can introduce yourself.
Sure. My name is Rachel Davis. I'm here from SouthCoast Hospitals Group. I work in community benefits, and part of my role is to work with providers in the community to assess community needs and develop and implement new programs to help fill those needs.
Yeah, thank you, Rachel. Beatrice?
Hello, my name is Medeiros, and I work for the Department of Mental Health. It is a state agency, and as such, it offers a multitude of services and programs, anything from inpatient services and outpatient, research, prevention, and treatment. My role at the Fall River DMH office is to assist individuals who have applied for DMH services and have been approved to identify what their needs are and to place them and match them with the correct service that best meets their needs.
Oh, thank you. Melissa?
Hi, my name is Melissa Costa. I am a clinical social worker. I actually do some outpatient work as well as do evaluations for crisis.
Okay, thank you. Michelle?
Hi, my name is Michelle Keith. I'm a local attorney, and I'm here on behalf of the Bristol County Commission for the Status of Women.
Okay, well, thank you all for being with us here today. So mental health, what exactly is the definition of that? What does that mean?
Mental health refers to a person's psychological or emotional health and well-being. So, and how they interact like with their environment and each other. So it's kind of how you feel.
Okay. Anyone else add to anything to that?
Yeah, I would go with the emotional and the behavioral, how outside influences and how we respond to them. There's a lot to do with our mental health.
So do we see a lot of mental health type of issues, challenges in our community and the people that you work with on a daily basis?
Well, sure. I mean, mental health is very common. I think people hear the term and they think of, you know, an extreme, maybe like a psychosis or a serious mental health disorder such as schizophrenia or bipolar. But mental health also speaks to, you know, feeling depressed, anxiety, and a lot of people have that. In fact, 1 in 5 American adults has a mental health issue at one point in their life. And it's not ongoing. It can change as your life changes.
It's fluid.
Yeah. So who typically, is there a specific population, age group, gender that's affected by mental health?
I would say mental health affects anyone and everyone. It's an equal opportunity, you know, mode of just anyone can, you know, it can be men, it could be women, it could be Latinos, African Americans, Asian, anyone can be affected by mental health, whether it's you personally or someone that you care about or love for could be suffering from some kind of mental health.
Okay, Beatrice, did you have something to add to
Well, I
that?
was just going to say, just like we have medical illnesses, then the brain can also be affected by a mental illness, and so it ranges socioeconomic groups, just like Melissa said.
So are there typical types, I don't know if typical is the right word, but typical mental health disorders that people are presenting to you in your organizations? Is it across the gamut, depending on the person's age? What types of things do you see on a daily basis?
So for the Department of Mental Health, we are, in terms of providing the services, to receive Department of Mental Health services, the person has to have a severe and persistent mental illness. So that's, the numbers for that obviously are not as common as the person who has, as Rachel was saying before, anxiety, depression, more of the things that most of us might be more familiar with or might affect us, even ourselves. So to have a severe and persistent mental illness, it means that the person has either severe mood disorder, I think some people have heard of bipolar, schizophrenia, schizoaffective disorder, maybe major depression disorder with sometimes psychotic features. So those are illnesses that are much more disabling for the person. And that's the type of person that we see at the Department of Mental Health, that we provide services for.
Okay. What about at South Coast, Rachel?
Well, yeah, so we do see a lot of behavioral health in our emergency department, and the term behavioral health kind of covers the whole gambit of mental health, substance use. We before the new facility opened in Dartmouth, we had the Rogers unit at St. Luke's Hospital, and it operated at about 97% capacity at average. So, I mean, it's definitely something that is in our community. I think people don't really like to talk about it. There's a lot of stigma. I mean, it's hard enough to talk about your feelings, but then if you feel like you're going to be, picked out or stand apart because of them, it makes it a lot more difficult. So I think, according to NAMI, it was 60% of American adults do not receive treatment for their mental health issues.
So that's a very high number. High number.
So as much as we see, there's almost equal that
don't go in for services. Right? And why do you think that is, that people do they not recognize signs and symbols, which we'll talk about in a second, or they just don't know where to go for resources?
I think there's some cultural barriers, depending on your ethnicity or your upbringing. Only crazy people seek help, and it's not necessarily that you're crazy, it's just sometimes you need that sounding board to kind of process things. And so that's where a lot of outpatient counseling kind of comes in handy. Just that non-judgmental person who can listen to what you're saying, kind of sound back what you're saying, and reflect, and then you're like, sometimes in our head things sound a lot worse, or they don't sound as bad or whatever until you say it out loud. And then once you get it out, it's like, that's not at all what I really meant or what I really was feeling. So having that outpatient therapist is really important. So but I think there is a lot of stigma attached to going to counseling, so I think that's a big barrier to people going and seeking treatment.
Right, I know you just mentioned cultural issues. Is it predominantly different ethnic groups over others that would seek something like counseling or going to Department of Mental Health or SouthCoast for services? Is it, like, as you said, a stigma or people feeling ashamed type thing?
So the social determinants of mental health, that's kind of like where we live, work, play, learn, our backgrounds really. That has been shown to play a role into, people who are at risk or who have certain inequalities like poverty, things of that nature, to creating barriers and also, like I said, putting them more at risk. But just because somebody does have one of those, it doesn't mean that they're going to develop a mental health issue. It's just, certain populations have been identified to be more at risk than others. So, it's when you look at mental health and what affects us, it's not just genetics, it's not just brain chemistry, it's not just your background or your environment or whether or not you've been exposed to trauma. It's really a combination of all those factors and how we respond to a given situation. So it's very complicated. There's no specific root cause.
Right, okay.
And also, in addition to all those things that you said, having family support or supports from your treaters makes it incredibly more beneficial, and the person usually has better outcomes in their treatment if they have support in place.
And if they're directly involved, because there's no one size fits all for treatment.
Right.
Some people, do medicine and therapy. Some people like peer support, different kinds of support groups, things like that, family supports. So it really, getting the person engaged in their treatment is going to help make their treatment work better for them.
So how does someone or a family member, what are some of the types of signs or symptoms or behaviors that you may or may not be watching or be cautious of or be concerned about if you see something? Because sometimes you might see something that someone else doesn't see in yourself.
Yeah. Actually, I think that the family members are the one that can be the most beneficial in this and identifying those things. They usually educate us as providers. They'll come to us and say, I'm seeing that this is really odd, or this person's behavior is really, maybe he's talking to himself, or she is just really hasn't left her room. My daughter hasn't left her room for weeks, or just kinds of things like that. When they start to tell us, they're really educating us on what the signs and symptoms they're seeing. So sometimes they might think, well, she's going through just a bad period or this will pass. And so that's when we try to educate about how early intervention is really, really important, and also help out with what the resources are, which is where Rachel comes in, or outpatient therapy where Melissa comes in, to try and educate about there is help, there's things that we can do. The sooner we intervene and provide assistance, then the better the person will recover in the long term. Although there is no cure, there is definitely lots of treatment opportunities, and the person can still function and do well if the person does follow a treatment program. So
I think that's a big thing you just said about the functioning, being able to function. Because there are, I believe the statistics were 1 in every 5 person has a diagnosable mental illness. But that doesn't mean that they're not able to function. They can still go to work, they can still hold down a family and hold down responsibilities. It's just the level of how much it impedes their function on a regular basis, whether it's school, occupation, family, things like that.
Right.
Yeah.
I think what you said before, that people, like the stigma, people think that you're crazy, or
Yeah.
Right.
when you hear that word mental health versus, 1 in 5. I'm sure many people don't realize that 1 in 5, and you said they're functioning, they're living their lives, they're working, going
So
to
it doesn't
school.
mean that just because you've been diagnosed with a mental health disorder that you're dangerous.
Oh,
no.
no.
But people assume that. They
Right.
hear that mental health and they're like, oh.
Right.
So
Exactly.
Yeah.
what are some of the examples that you would say, like a mental health problem that doesn't have to do with dangerousness? Versus like when do you start to get to that line where it's starting to become a danger to the person or a danger to society?
I see more of the danger in the psychosis sometimes, like there are voices or they're seeing things that are telling them to hurt themselves or telling them to hurt others. That's when you start to see more of that dangerousness, and that's when a lot of times we'll come in as crisis clinicians and issue a Section 12, which is holding someone involuntarily so they can seek treatment for so long. So that's important. I think that's where that kind of that dangerous, whether they're a harm to themselves or to others. But so many people are not a harm to themselves or others. They're dealing with a depression, or they're dealing with some kind of anxiety. Those are really huge in the outpatient world that I see. Even bipolar isn't necessarily dangerous.
exactly,
Yeah.
that's my experience too. I work with a severe and persistent mentally ill, and the majority of our clients are in fact really just persons that you can work with. So we enjoy working with our clients. We learn a lot from them. It's a very small minority that really can get violent and can get aggressive. It is our job, and it is DMH takes this very responsibly and very seriously, that we have risk mitigation policies that we have implemented in all of our programs. So that once we know that the person has the capacity or is not psychiatrically stable, that might become dysregulated and might need some assistance, then we have safeguards in place. For instance, one of the big things is we have a safety plan that we develop with the person so that we can identify, how do you know when things start to become not going well for you, so that we need to intervene? What would best help you when you're not feeling well for us to intervene, and who do we call or what do we do? And, or if the person is agitated, for that person, is it best to back off and let them cool off on their own, or is it best to say, hey, do you want to talk about it? So they're just, a person with a mental illness is just like any of us. Sometimes I want to be left alone if I'm not, feeling my best, or some people want to engage. So in the same way, we learn that about the persons that we serve, and so so DMH is, takes this really seriously about identifying ways to mitigate the risk in the community so that that person is safe, is served, the other clients are safe, and then the staff as well.
All right, thank you for that explanation.
But the majority of clients are safe to work with.
Right. Well, that's good, because I think people automatically think, like you said, that they're dangerous, they're going to hurt someone or hurt themselves. We see so many cases, in the world and in the news sometimes, that I think when they say, well, there's mental health issues, like, oh, it's going to be, a crime or something like that. But depression, like you mentioned, is very common, in the populations. Probably, I'm sure, loss of appetite, or maybe not sleeping or sleeping too much. Those kinds of things. I'm thinking that family members, might be concerned with.
Right, losing interest in things that they enjoyed to do before.
We look at like energy levels, concentration, ability to focus, if they're hearing or seeing things, if they're having any thoughts of suicidal ideation. any thoughts of homicidal ideation, you know, if they engage in any kind of self-injurious behaviors, which are things like cutting, head banging, scratching, burning, punching yourself on purpose or punching walls on purpose. And even self-injurious behaviors isn't necessarily suicidal behaviors. It's an unhealthy coping skill that I think we're seeing an increase on, especially in our adolescents. And so just trying to teach them healthier coping skills and healthier ways to, you know, deal with the depression, the anxiety, the social stressors that especially our adolescents are going through right now with all the social media.
Because I'm sure a lot of it is hidden. People don't realize that you're trying to keep it, you know, to yourself. You're trying to keep it secret, whether it's an adolescent or, you know, adults, that they're functioning and going forward until maybe something happens that, you know, someone finds something out about them, or they have a breakdown, or they just feel bad, or, you know, start crying. Or with adolescents, we see, you know, different types of things happening. So it's, I think, signs and symbols that people can be looking for, whether it's adults in children's lives, teachers, community members, is something that I think we should be thinking about and be aware of.
And with the younger children too, signs more often are behaviorally focused. So like, you know, aggression, being argumentative, going out of their way to avoid things like, you know, school and things like that. Nightmares, I think.
So an adolescent will not be lethargic or laying on it traditionally, but not look like a depressed person that you would imagine. It's definitely what Rachel has described. So you need to be aware of those things.
So what, Michelle, I'll direct this to you, the legal ramifications for mental illness, mental health, if you, I mean, adolescents, I would assume that the parent or guardian could, you know, make those decisions. But if it's an adult that I would say maybe does not think that they have any issues or does not want to seek any help or treatment, you know, what could families do? So I guess a two-part question for you.
First of all, you know, people suffering from mental illness are protected by the law. Okay, their fundamental rights. They have a right to use a telephone. They have a right to get mail, to have visitors, to privacy, to dignity. They have a right to an attorney. And then this year here, Governor Deval Patrick, on his last day of office, after 10 years of trying to get this passed, did give people the right to fresh air. So I think most importantly, to have somebody within your family who's advocating for you is paramount. And then to make sure that you know that you have a right to an attorney, no matter what your financial status is, is very important. And I would suggest that people check out the Supreme Judicial Court site. It's the Mental Health Legal Advisors Committee.org, I think that is. We've got the
we'll have it running at the end of the show.
Available. And there's a resource page that is a fantastic starting point for anybody advocating on behalf of a family member, a loved one, a friend who is suffering from mental illness. So I would suggest that they go there and start with those links.
Okay, so you mentioned, I believe, Melissa, about the Section 12s and some other times legal things that would be, I guess, the way I understood, will just happen even if the person refuses, that you would have the right to do that as a clinician, or how does that
work? So the
work?
Section 12s are issued either by an attending physician, a licensed independent clinical social worker, or like an ER doctor or a psychiatrist. They can issue Section 12s, and that's
Police
based
officers
Police officers, okay.
Yeah. So they can issue them, and it's an involuntary commitment, which allows them to be evaluated against their will. Although for the most part, you can get them to cooperate, and then based off of the evaluation, the clinician then makes a decision with the attending physician. It usually happens at the hospital setting for adults. We do try, if we can safely bring them out into the community, we will. Kids, we can go out to the home and evaluate them, and then if we feel that they are a harm to themselves or others, then we can issue the Section 12. And it allows time to determine an appropriate level of care. Maybe that person needs to go into a higher level of care, which would be a psychiatric hospital like SouthCoast Behavioral, and where they can seek further treatment at that point.
Okay, thank you.
It's only good for 24 hours, correct?
I was going to ask, what's the time frame? So it's 24 hours, and after that the person can leave if they choose to, or?
If they're being held on a Section 12 because they're determined to need a higher level of care, then we go out and reevaluate them. If we haven't found an appropriate facility for them within those 24 hours, then we go out, reevaluate them, and redetermine whether or not they continue to meet Section 12 criteria. and continue to hold them.
Okay. And you mentioned, I'll mention, and Rachel, maybe you could talk a little bit about the new facility, the South Coast Behavioral Center. Is that what it's called?
SouthCoast Behavioral Health.
Okay.
So it's our new psychiatric hospital, and it increased our inpatient bed capacity to 120 beds, which was something that's very needed in this region. So that opened in the fall, and it's opening kind of in bits and pieces,
Sure,
right, until it's at full capacity, which should happen after the beginning of the year. So,
So that's a new resource
yes.
in our community.
Yep. And like Melissa said, somebody would come in through the ED, be evaluated, and then, from there. So,
Do you deal with Section 35 as well, or just Section 12?
No.
I know, Beatrice, you would mention Section 35 for substance abuse. There's some of the different.
Yes, Section 35, it is through the courts. So someone, a family member or probation officer can petition, go to the court and petition that their family member or loved one is at risk, putting their life at risk with the use of substances, and that there needs to be inpatient against their will.
Yes.
And the Section 35 now it's changed. There used to be a 30-day confinement. Now it's up to 90 days. But doesn't mean the person stays for 90 days. Unfortunately, there were not enough resources for the Section 35 in private facilities. I believe High Point is the one that has the contract in this area. And when there was an overflow, the women would have to go to Framingham. And this is a civil commitment. The person has done nothing illegal. They may have used substances, but they have not broken the law in any way. And to have a woman go to Framingham, it really can actually be traumatizing. So the Department of Mental Health has a new initiative, and is actually opening up in the vacant space that we had at Taunton State Hospital a Section 35 program for the women.
Okay. Well, that's good to
So
know.
apparently it's been in the works for almost 30 years that they wanted to take that away from Framingham
It
and
just
bring
sounds
it
like
to
punishing women too.
And I think the family members too that go to visit to try to support their loved ones,
Traumatic.
it's traumatic for them as well.
And then at times a family member would say, well, if there are no beds at High Point and she has to go to, then I'll just back off. I won't follow through with the 35. So then there's a lot of guilt, and there's a lot of mixed emotions about doing the right thing and holding the line while making sure the person is still safe. So it was very difficult. So this is something that we're really excited about. And in the new year, I think in January, the new Section 35 will be opening up.
Okay, well, that's good. That's good information and good to know.
And I want to mention that at that website that I mentioned earlier, there's a whole fact sheet on Section 12s. There's a whole fact sheet on Section 35s that people can reference to understand it more.
Right, and Beatrice, you mentioned the pink slips too. Is that part of that?
That's the
12.
12.
That's the 12,
That's
okay,
Section
okay,
12,
just
yeah. So
making sure.
because the form, one of the is
That was a pink slip, I see,
think that,
okay.
sometimes we just call it a pink slip, so.
I see, okay. So you mentioned that we know that there's no cure for mental illness. If someone, finishes their treatment, they were in the behavioral hospital, they've moved on, they're still seeing their counselor, what is the next steps for that person, and what should their families or loved ones be doing to help support them?
Could I just correct one thing?
Sure,
There is
please.
no cure, but there's a lot of people that can have bouts of depression, or what we call an episode, and be completely symptom-free for a very long time.
Okay.
And if they work with their doctor, so if they've had the best treatment, which is a combination of medication and the talk therapy, and they talk to the doctor about tapering off their meds, they can, if they do that safely with their doctor, they can even be off medication.
Oh,
So
that's good to
there
know.
are
That's great.
instances where it would be, and the anxiety, the same thing, that they can have a bout of anxiety, there's a stressor in their life, they work with their doctor. Or I know someone that, her husband had passed away, she was in her 30s, and she waited a whole year. I don't want people to think, well, someone passes away, you're not supposed to have a feeling. You have a big
course,
loss, you're going to be
sure.
depressed, you're going to be sad, you're going to cry about it. But if after a year you're still not sleeping well, or you're still losing weight, or gaining a lot of weight, or isolating, not wanting to get back to the things that gave you pleasure, then it's something to consider. And sometimes you can just go with your primary care physician, doesn't even have to be a psychiatrist.
Sure.
It could be a divorce or a loss. And you can be on a medication for a short amount of time, anywhere from 6 months to maybe a couple of years. And then with your doctor, if you make the decision to taper off the medication, you can be completely symptom-free, and it can be lifetime. So I don't know if we want to call that, because that almost, to me, it's almost like a cure, but,
Right.
We say there's no cure, but there's certainly, hope
Right,
that people can
absolutely,
have,
absolutely.
Be functional.
Functional
yeah, They can have episodes and then be completely symptom-free for the rest of their life. Particularly, and I think it goes back to early intervention and prevention. If you try to get the help early on, some of the medications that they have can really have some protective factors so that the person doesn't have to have a relapse in the future to their mental illness. So I'm sorry I didn't answer your question, but
No, that's okay. That's perfect.
I just wanted to put that out there.
Sure,
So.
absolutely.
Yeah, 'cause I think the biggest thing is that there is hope, and I think so many times people who are suffering with a major depression, they lose sight of that hope.
Right.
And so just making sure that there is hope. It takes some work, and it takes some supports and some work. But I've seen so many people turn around, and just when you kind of reflect with I'll reflect with my clients, and just to hear like, wow, remember when this and this was going on, and now look at you today,
Right.
and medication, that's a personal thing along with the doctor, but so many people are like, oh no, they're anti-meds, and for that
Right,
person,
true, yeah.
that could be what they need, just like a diabetic might need insulin. It's
right.
not a bad thing. It might need to be tapered, it might need to be changed. That's one of the biggest frustrations as a clinician in mental health, is that no two meds work the same for any one person, or for for any two people. It ebb and flows, and what works for one might not work for the other one.
Right.
So that can get a little frustrating as you're trying to figure out what works best for you and your brain chemistry. But there is hope and there is treatment out there.
Right. I mean, you made a good point, because with the stigma and people in the workplace or at school of, well, you have diabetes and we know what to do, we can help you, we can talk about it, versus, you might be depressed or something else is going on, and, you might be treated differently.
Yeah, you can't just get over it. So many
Right.
times it's like, oh, just get over it,
move
you'll
on.
be fine, move on. And
Right.
for someone who's really living in that very, very dark, dark place, they can't see that. And so that's where a lot of this treatment kind of comes in
Right.
handy.
Or they might not want to say anything too, or want their coworkers to know that, they're going through something.
Well, they may not want to lose their job.
Right, Michelle?
Yeah.
Right. Be afraid.
What would happen if someone, missed work because they were in an inpatient hospital and their job was giving them a hard time about
Well, they are protected by the law, and people do deserve to have reasonable accommodation based on what's going on with them physically and mentally.
Right.
And that's I think a whole nother topic for maybe an employment law.
Right,
Issues in the
absolutely.
workplace panel.
Right. Good idea. We always come up with other topics when we're filming these shows.
But the law
definitely.
does protect people.
And that's really, it's also at another level that always breaks my heart, is to have someone who actually, I had in particular, this one lady was phenomenal. She actually held a job, which is a third shift job, which I think for me, I don't know if I could ever work third shift, but so she worked really hard. She had a serious illness, which was bipolar illness, and once in a while she'd get, even if she did everything correctly, she followed her prescriptions. After a while of making some mistakes, she took her prescriptions exactly as prescribed. She would still get really depressed and become really suicidal, so she would have to go in the hospital. And she had a loving family, and she would miss work. So she was able to get just a genetic letter about why she missed work. But the other very sad part of that I think sometimes we don't think about, is she couldn't get flowers at the hospital from her coworkers because no one knew.
Nobody knew.
Right.
No one went to visit, aside from her family members that were really loyal. No one knew, so she didn't get that support that we would get if I was having, some other kind of surgery or some other kind of. So we always used to make, because here she is working really hard, holding on a job, dealing with this, and has to hide it and doesn't get that support. I just think that's why it's so important to recognize that that stigma does affect not only, people coming out and asking for services, but when they are doing everything that they need to do, not getting that extra, TLC that they deserve.
And individuals and families can, there's great supportive services within the community and organizations, and NAMI, the National Alliance
The mentally ill.
on mental illness, I think is what it is. They are fantastic, and we actually have a chapter in Bristol County. So you can go to NAMI.org for more information for that. SouthCoast also has a new resource available for anyone to use. It's open to the public. It's called Behavioral Health Connect, and it has every kind of behavioral health treatment, supportive service. It has social service agencies, So all those good wraparound services, community support groups, and that's available at bhconnect.southcoast.org. And again, that's for anyone to use, and it's very user-friendly.
Oh, that's good, thank you. We'll have a list of resources at the end of the show. So final thoughts as we wrap up our show. Does anyone have anything to add before we close?
I would just like to say that, you know, just being able to talk about it is the first step, and not being afraid, rather, to share your feelings if you are, you know, feeling upset or feeling a little off is big, you know.
Thank you.
I was just going to say, sometimes people have no idea where to start, so it's always okay to start with your primary care physician. If you're not feeling safe, obviously dial 911. You can go to the emergency department now, it's the emergency room, and go in and ask for help. They will be able to direct you, because not everyone knows where the crisis centers are. Obviously, there's a crisis center at in Fall River at Corrigan. I know that in New Bedford it's at
Child and Family
Child and
Services.
Family. But if you have forgotten all of these things, because sometimes in crisis we do, just go to the emergency room or call 911. You know, getting help is the way to then get better. And there is recovery, there is hope. While there's breath, there's hope.
Yeah, I would definitely echo that, as far as, you know, just seeking out treatment, seeking out providers, that there is, even though there is a shortage in particular areas, but, you know, being persistent and being your best advocate. You are your best advocate for yourself, and you know yourself best and what you need. So reaching out for that and getting that.
Definitely. And advocacy is something that the Commission is working on. All of us, you know, sitting here believe in advocacy, not only for women, but for, you know, women and families, you know, everyone in our community on this issue.
And I would add that everybody has the right to basic human dignity.
Right.
And part of that is good health. It's not going to get better if you hide it and you don't ask for help. So as a family member, ask for help. As somebody who's potentially suffering from mental illness, ask for help. Because it's not going to change unless you take that first step.
Well, thank you all for being here with us today, and thank you for watching Voice of South Coast Women.